Today we will be talking about an introduction of bladder cancer, the pathophysiology behind bladder cancer, the clinical manifestations that we see in a patient who has bladder cancer, the collaborative care we provide to a patient with bladder cancer, and the nursing care we provide. The bladder is a hollow, balloon-shaped organ in the pelvis. It is part of the urinary system, and urine made in the kidneys will pass through the ureters to get to the bladder where the urine can be stored. The bladder has flexible muscular walls that allow it to expand and contract. When the bladder is full, the muscles will tighten and urine is able to be passed out of the body through the urethra. With cancer of the bladder, normal cells become malignant, causing changes to the normal functions of urine production and urination. These will be discussed further in the video. It is important to note the high probability of developing bladder cancer. According to the Canadian Cancer Society, 1 in 27 males and 1 in 84 females will develop bladder cancer, and over 50% of these diagnosed patients will need to undergo an ileal conduit, which is a system of urinary drainage created by using the small intestine after removing the bladder. Cells in the bladder sometimes change and no longer grow or behave normally. These changes can lead to benign tumors. Most bladder cancers start in the innermost lining of the bladder, which is called the urothelium or transitional epithelium. It is important to note that 90% of bladder cancers are urothelial carcinomas. When the cancer is only in the urothelium, it is termed non-invasive. As the cancer grows through the other layers of the bladder wall, it becomes invasive and more advanced, meaning it is harder to treat. I want to mention some risk factors for bladder cancer. The risk factors include being male, being between the ages of 60 and 70 years old, rubber dye exposure, chronic abuse of fencetin-containing analgesics, chronic recurrent renal calculi, chronic lower UTIs, and smoking. According to a study compared to non-smokers and light smokers, the initial tumors in heavy smokers are more likely to be high-grade with a more advanced clinical stage. In fact, cigarette smoking is the leading risk factor for bladder cancer and is reported to be the causative factor for over half the cases of bladder cancer. The signs and symptoms of bladder cancer include painless hematuria, which is usually the first sign, irritative urinary symptoms that include frequency, urgency, and dysuria, and in advanced stages, there is pain from metastatic disease. And now we'll talk about the collaborative care of a patient with bladder cancer. The collaborative care includes surgical therapy, radiation therapy, chemotherapy, and intravesical therapy. We'll start with surgical therapy. For superficial tumors, there are two main types of surgery that are used for diagnosis and treatment. The first technique is called a transurethral resection with fulguration. Fulguration means to destroy tissue by means of high-frequency electrical currents. In this technique, a cystoscope is used. A cystoscope is a small tube with a camera and a light on the end of it that is inserted into the urethra. Therefore, an abdominal incision is not necessary. A blade is then inserted into the cystoscope to remove the tumor, and the recurrence rate after this treatment is low. The second technique is called laser photocoagulation. This treatment can be conducted many times and is therefore used for bladder cancer recurrences. The procedure involves inserting a laser through a cystoscope and using the laser to destroy the cancer cells. The advantages to this technique include no blood loss, minimal risk for perforating the bladder, and no need for a urinary catheter after the procedure. However, the disadvantages of this procedure include the fact that the tumor is destroyed and cannot be examined for grading and staging. But what happens when the cancer becomes more invasive? Then, either a partial or a radical cystectomy with urinary diversion are used. In a partial cystectomy, the portion of the bladder wall that contains the cancer is removed,
along with a margin of normal tissue. In a radical cystectomy, the bladder, prostate, and seminal vesicles are removed in men, and the bladder, uterus, cervix, ovaries, and urethra are removed in women. In both procedures, urinary diversion is then completed to reroute the flow of urine out of the body, usually with an ileal conduit as mentioned earlier. Next, radiation therapy can be used as the primary therapy when surgery cannot be performed to resect the tumor. Radiation therapy can also be used after a cystectomy. Furthermore, chemotherapy can be used before or after bladder resection surgery. Chemotherapy is often used to treat metastases of bladder cancer. The common chemotherapy drugs used to treat bladder cancer include cisplatin, vinblastine, and methotrexate. It is also common to see radiation therapy combined with chemotherapy after bladder resection surgery to treat bladder cancer. Finally, intravesical therapy involves inserting chemotherapy or immune-stimulating drugs directly into the bladder via a urethral catheter. This is usually done every week for 6 to 12 weeks. The drugs are retained in the bladder for about 2 hours, and the patient's position is changed every 15 minutes to fully cover the bladder's interior surface.
So what is the nurse's role in caring for patients with bladder cancer? As discussed earlier, diagnosing and treating bladder cancer requires surgery. As always, post-operative management involves patient teaching. Patients need to be instructed to drink large volumes of fluid and avoid alcohol. The patient is also taught to self-monitor their urine. During the first several days after the procedure, their urine should be pink in color. If urine is bright red or containing clots, the patient needs to be taught to report this to the healthcare provider. 7 to 10 days after the procedure, the patient may find their urine is dark red or contains rust-colored flecks. The patient needs to be taught that these findings are a normal part of the healing process and represent scabs shedding from the healing tumor. Post-operatively, nurses will give opioid analgesics to help reduce pain. Stool softeners may also be required to help reduce strain and pain. Nurses should also encourage patients to enjoy a 15 to 20 minute bath 2 to 3 times per day. This helps promote muscle relaxation and reduces the risk of urinary retention in the bladder. Nurses also have an important role to play when it comes to coping. Nurses help patients and families to cope by providing complete and accurate information, answering questions, and remaining open and available to all of the client's needs. Abdominal stomas and ostomy bags often leave patients with self-image issues. Findings show that this often interferes and leaves patients feeling unsatisfied with their sexual life. For this reason, it is important for nurses to pay attention to and address concerns regarding sexual activity. Nurses also need to educate patients on the importance of regular follow-up care.